Okay, welcome everyone. We're going to go over for the NeoCardio Labs participants how to do the echo and how to use the Philips Epic. Basically, this is mostly geared at technologies that will be scanning patients that are adult participants. So the machine is pretty straightforward. It's a Philips that we use. Basically, if you look on the keyboard, there's the power button and then there's a moon. So when we click the power button, right now it was in what we call the sleeping mode. If you re-click the power button, it's going to close off the machine completely, which then to reopen sometimes it takes a long time and it's a mess. So we prefer to use the sleeping button as much as possible to avoid having to reset the machine each time. So this is just example of opening the machine, and then if I press on the sleeping button, it's just going to go asleep and it's going to be easy. So here, where we tend to keep the material, so you'll see that we have many probes. The probes that we typically use for adults is currently the X51, which is an adult 3D and 2D probe. We may get an S5 also, which is just bidimensional and sometimes gives better image quality. But for now, we have the X5 to do both. So where is this probe usually? The probe is usually kept in a box that is here, because we don't like to have all the ultrasound probes like attached. So you'll see that the box, we have another probe in here, NeoCardio Lab, and then you pull the probe, you close the box, and put back on the side opening. Okay. The echoes have to be done ECG gated. Typically on the machine, what's attached is the auxiliary ECG that attaches to monitors. Ideally, you're going to have a lot of like outpatients, so we're going to use the adult ECG capturing device, which typically is in the box that is on top. And in this box, you will find foam electrodes. These are the foam that we use mostly for pediatric. They're not great for adults. And then you have adult electrodes that, currently the version that we have, they look like this. And then you can clip and then detach. Right now I have them attached on me, so it looks like kind of these things here. So you have also the cable will be in here. So right now this is the pediatric cable. You have the adult, I have the adult cable in my hands. So I'm gonna reclose and put back there. The cable has a little white dot. This white dot has to correspond to the white dot or right hand side of the entry port. So I'm gonna plug myself, okay? And it's just a gentle pressure. If it doesn't fit, don't push too hard because you're gonna break the cable. Let's say the probe, as I mentioned, is not attached to the machine. It's very easy. You can detach like this and then attach just by gently pushing. There's really not much pressure to be done to avoid breaking the probe, and then you reclose it in safety position. The machine has a pedal that goes in 3 positions. The first position is rolling in only one direction. The second position is to roll in all the direction, and the third position is to lock it. Once it's locked, you can adjust the main power station with the button that's here. So you have to click, move it up and down, and re-click. Okay. So now we're going to open the machine, and we're going to go over the probe and the adjustments of some of the setups. And I'm going to send you in the video our exact imaging protocol and sequence, as well as today I'm going to go over how we do 3D volume acquisition for the LV volumes and the RV volumes. So the first thing is that you have a touch screen and you have the main screen. So if I go in patient in touch screen, there's a zone that's called the work list. Okay, and the work list right now, there's my name. Let's say there's no name. We're going to pre-create the request in our system. Sometimes you have to update a few times for the request to appear. So the update button appears here. It's awaiting the connection. And then my name appears, so then I can click on it. And once I click, I can click 2D and start my echo images. Okay.
The cases for research are already registered and we get it.
We're going to register it for research.
Yeah.
Now you can see that on this image screen, there is no name. Let's say there's names that appear. We don't want the name of the patient because we want to remain blinded for research. So on the touch screen, there's a place called Utilities. Within Utilities, there's the system. And in system, you have Hide Patient Info. So if I click Hide Patient Info, I have this possibility. The other thing that you have on this system, some technologists, like the previous that we just trained, they like to accept the image prior to store. I don't do that, but if you like that, there is the option of activating this under Accept Prior to Store.
What happened if you accept?
So if you accept prior to store, it's going to show you your loop before recording the loop. Okay? I don't activate it, but it's a choice if you want to activate it. I'm going to go back to my X5, and I have many presets. We have specifically created one that's called the Sarah B Study preset, and this preset is what we find gives the best imaging quality. Okay? Now, I did use my request to do a previous scan, so I'm going to go under my, because we're going to continue doing the scan. So I'm going to go back to 2D, I'm going to go to review, and in review, this is the scan I started already on myself, and we're going to add the images. So if I click on this, it won't let me add exam, paused.
We have to end the exam in order
I
to
have,
send it in
exactly.
the network. If
Yeah.
you don't, it doesn't.
No, it sends automatically.
Oh, it sends.
It sends as you acquire. It's not at the end.
It's yeah. Just set up like that.
Exactly. It's set so that it sends as we go.
Because we have GE, but I've worked with this, for abdominal.
Oh, great.
But,
So here, I already had the images acquired myself. I'm just going to click on it and do append. I'm going to add images.
Append, you continue.
Yeah, I can continue. So I'm going to go to 2D, okay? And right away, you can see that I'm on the Sarah B preset, but sometimes it might go on adult like this, and it's not exactly the best preset I find. So I go Sarah B preset. What's particular about the Sarah B preset, so you can see you have ECG here that appears, and the loop is a retrospective acquisition, and it's 20 beats, okay? It doesn't mean that we want everything to be 20 beats. We want things to be 2 to 3 to 4 beats, okay? But if you go up to 20 beats in a sweep, we don't mind, okay? The particularity with Philips is that your loop often corresponds to the ECG tracing in the bottom. So let's say I press on freeze, and I release the freeze. As soon all of this, if I press acquire, it's gonna record this part. If I repress acquire, it's gonna record from the moment I pressed initially acquire to the second acquire button press.
Twice you have to.
Yeah, so let's scan. I'll show you. Many people like to activate something called max view. Max view will increase the visualization of your screen compared to here where you see kind of what you've acquired before. So I'm going to go to max view, and let's say we're going to take image of the LV. So once I'm here, I can adjust my focus. Focus is on the side. I can press on focus and increase the size of my focus and repress. I can adjust my sector size, okay? And then the things that corresponds on the button, on the bottom, here you see 2D position and cursor. If I use the left button on the keyboard, it's gonna go to 2D position. If I use right button, it's gonna go on cursor. And then I can move my cursor where I want, okay? So for the buttons, briefly, if I press on the button, it selects the action. So CW, PW, 2D, color. If I press on CW, okay, and I turn my wheel, it's gonna increase or decrease the gain of my CW. If I press on PW and I increase or decrease, it's gonna again change the gain of my PW. If I press on 2D and I increase or decrease, it's going to change the gain of my 2D. And if I go on color and I increase by turning, it's going to change the gain of the color. The buttons also that you might be interested in is scale and baseline. So let's say for my filter of my color box, I want to change my scale. I can increase or decrease my scale, which is the filter velocity. CW, same thing. I can increase, decrease my scale, and I can change my baseline too. Increase or decrease my baseline. Okay? Same thing for the PW. Increase and decrease the scale, and change the baseline position.
And tissue Doppler.
The tissue Doppler is here. If I want to change the gain of my tissue Doppler, I need to turn the wheel of PW because it's a pulse wave. So by doing this, you can see I'm increasing the gain of my TDI. Okay?
And also there is a baseline and a scale for that.
Baseline and scale is the same for TDI. M mode, I press on M mode button, or I can even press the touch screen. Okay? On M mode, I can move my cursor towards the M mode area that I'm interested. So let's say I would do an M mode of my TAPC. Not sure I'm going to see my RV very well, but let's say I'll put it on my LV for just a show. So here I'm getting an M mode of my thing. I can freeze and then go back to where I preferred. Let's say I prefer in the back. I can go like this and acquire. Okay. We don't ask you to do any measurements, just to acquire the image, because we'll do the acquisition post-processing. Let's say I go back like this, and I'm on M mode. Okay. I can also do angle correction, but it doesn't give as a good images.
You change the
resolution.
frame per second.
Exactly. Exactly. It changes your frame per second. Okay. A few other elements. Let's say I want to do a zoom on the image. I can click on my button zoom here, move my box. So this is box position. Let's say I want to change the box size. I go to box size, narrow my box size, and I re-click zoom, and now I can see my mitral valve. Acquire, it's going to acquire all this. I go back to 2D, goes back to my preset like this. Let's say I'm here and I'm doing color. I'm moving my box. I change my box size. Each time I adjust the box of color, it resets my loop. So that's different from GE, where I could just move. If in GE, you could just move and it's going to record your movement. In Philips, it doesn't. It actually resets. Each time I move, it resets. So you really have to position your box, adjust what you want, because each time you do an adjustment, it resets your loops. So I say this. Let's say I want
to acquire. When you push acquire, how many loops?
It's gonna store whatever you had.
Oh, the whole buffer.
At least. So if you had 20 beats, it's gonna take 20 beats.
Oh, you actually loop length is 20 beats.
20 beats.
And you said for the protocol you put it on 20.
I'll put it on 20, but I'll give you an example. Let's say I do this 1, 2, 3, acquire, and then 1, 2, 3 again, acquire, and then 1, 2, 3 again, acquire. The 3 acquire that I've done just captured these three beats each time. Because each time I've pressed on acquire once, it resetted. So it's not going to take the 10 beats that I had. It's going to take 3 beats, 3 beats, 3 beats. So let's say
if you have 20 beats and you acquire, it
takes the 20
beats. Yeah, I understand.
Okay. Yeah. So another thing, let's say I'm in a color option, okay? And here you can see I'm losing a lot of echogenic power. Yeah. So there's the option of doing black and white suppress. It's going to remove everything that's outside of your color box. So let's say I narrow my color box, it's just going to follow the color box. And I can move my color box. So I'm in box size right now. I can go to box position and move my color box where I want. And I can use the option also color compare, which is here, which shows your B mode at the same time, if you want. So here I'm like this. I can go back to box size, narrow it, box position, just go on the mitral valve. And if I acquire, it's going to take those 4 beats. And if I acquire now, it's going to take the 5 beats that followed that beat that I acquired. Okay? From here, I can press to go to cursor. And I can go where I want and then do PW. Adjust my baseline, freeze, acquire. Same thing, I can go here, PW, adjust my baseline, freeze, acquire. Now, because this is a 3D probe,
You have to freeze and acquire for the thing. You cannot just acquire
if you acquire it, you're going to acquire it as a loop.
as a loop, not
Yeah,
just a.
not just as a still
Yeah,
frame.
Yeah.
So let's say you're here, okay, and you're happy with your window. The advantage of the 3D probe, and that's really your choice, is that you can use the rotate option to rotate it in 3D to get your two chamber without even moving your hand.
Oh yeah.
The other thing you can do is that if you're at 0, you can go in quick eye rotate where there's already a preset to get the two chamber, acquire, and you can also go get your three chamber automatically, or sometimes you do have to adjust the rotation. So this is just so that you don't have to move your probe, and you can use the property of the 3D probe for that. Okay? So these are pretty much how to use the different setups. Let's say you want to work in time. There's also the option of doing a loop type in time, and typically we set it at 8 seconds. So just we don't lose any research material. Okay? But it's more typically in beats. Now, let's say I want to do 3D, which is the portion that is a bit more tricky. For 3D, what we're interested is that we want full volumes of one full volume of the left ventricle, one full volume of the right ventricle. You have to make sure you go back to your 0 degree, okay? And when you're in your 0 degree, you have the option here of doing what we call a full volume. If you can show the button, RZ, full volume. To do 3D, you absolutely need to have the ECG on, okay? Philips has two ways of acquiring 3D. It can acquire 3D by sending planes of ultrasound waves in different directions to increase the temporal resolution, or it can do multiple capture beats where it fuses different beats together. What we want is one of each, okay? On the image, you have here the frame per second, or the hertz. It tells you 10 hertz. To do 3D volumes, I need at least 2830. If I have less than that, I won't be able to reconstruct the volumes. The image that it will show you on the screen is the two planes. The plane that is typically the 4-chamber or the lateral plane, and then the plane that is typically the 2-chamber view or the elevation plane. The cone of image acquisition is appearing here. So if, for example, I'm on 3D rotate, I can show you how the cone looks like. It looks like this. There are the options of changing the size of your cone or moving your cone. So for example, the lateral size will change the image cone on the lateral perspective. The more narrow I am, the best you have in terms of resolution. Same thing for elevation. I can move the cone to increase or decrease. So you can see if I go to max, it gives me a big cone of acquisition. Okay? So now the other thing that I could do when I narrow is that I could adjust the position of my cone. So this, if I go to lateral, I can move my lateral cone. You can see how it moves like this. If I go to elevation, I can move my elevation cone. Same thing. To narrow it to the left ventricle. So let's say, or to the right ventricle. So let's say I'm trying to get the left ventricle, more gel. I'm doing this on myself, so pardon the quality of the image. I'm gonna go back to 2D. Oh, one thing I didn't mention is that there is an algorithm from Philips where you can use, which is called iScan, which is gonna try to adjust automatically your image when you click here. So sometimes you can use that to improve the image quality. So let's say I'm here, I'm happy with my image, I'm gonna go to full volume. And you can see the line that intersects. So I'm gonna go to lateral position and really go in the middle of my left ventricle. Ideally, I would like to have all my walls, including the apex. So I try to narrow it down to here. I decrease my lateral size until I have the most narrow sector. Same thing for my elevation. And then I could adjust also my elevation until I'm happy about getting all the walls and my depth also. So now I have a 16 hertz. The option that you want to use is what we call the high volume rate capture. It automatically doubled to 30 hertz. Acquire. One thing you could do, let's say I press freeze. By pressing freeze, I can go back and do a cineplay. And I can see all the beats that the machine has recorded until I press freeze. I can then select the beat, so I can decrease my cycle, and I could go back in the beats of interest. So you see, I narrow it to this, and then I can go and select the cycle of interest. Let's say that I did capture previously an image of interest, and I was happy. I could go back and just narrow it, and then acquire this one. I'm gonna continue with 3D, and I'll show you how to do this in the 2D, okay? So let's say I go back in 3D. What we wanna get is a high volume rate capture that encompasses the entire LV and one that encompasses the entire RV. So right now I'm at 20, it's not enough. So let's say I can narrow it and then see if, now I get 24, it's not enough. So sometimes you don't have a choice and you have to do a 4-beat capture. The 4-beat, ideally, the patient should not move, because if not, there's stitching artifact. I have to wait for the entire cone to be filled and a few beats before I acquire it. Because let's say I show you cineplay and I go back to the cycle initially, it will include some of the initial stitching artifacts of recomposition of the image. So I'm gonna remove my freeze and I'm gonna go back. It's acquire. So it's gonna capture the last 4-beat capture at 44 Hertz. So ideally you want to have above 30, and we take one HVR or a few HVR that are nice. You take whatever you think is nice, and you do the same thing with a 4-beat capture. And then I'm gonna remove the freeze, and we try to do a right ventricle. So I'm gonna go back to HVR, and then this time you can use your lateral position, try to go to the right ventricle. So decrease my lateral size, really go to the right ventricle, adjust my elevation, same thing, change my elevation so that it really takes the entire right ventricle as much as possible. And then now I have 45 beats and I acquire. Obviously I'm not in an optimal position to get an RV, and I acquire. So I'm gonna go back to 2D. So let's say I'm here. If I freeze, I can go back in 2D frozen, cineplay. It's gonna show me what I just imaged. So from here, I can also select the beats that I want or the cycle that I want to record. So let's say I'm here. You see, it's showing you what you're gonna record. If I acquire this, it's just gonna record this. Okay? So that's how to like retrospectively adjust if you're interested. Okay? There is the possibility of also adjusting the hertz of the probe. So right now we are set in a resolution mode, which is using the highest capacity of the megahertz of the probe. If you have very deep structure and you want to go more in penetration, you can turn it toward more of a penetration, which is lower hertz, so less resolution, but more deeper structures that can be imaged. Okay? Zoom, we talked about it. Focus, we talked. Depth, we talked about it. The difference between the Acquire 1 and Acquire 2 is that the Acquire 2 will capture raw images. Acquire 1 will capture the same frame per second, but it will compress the images for each of these frames. We like to use Acquire 2 for the images or clips that we will be using for strain or speckle tracking. These corresponds to the parasternal views at the mitral valve, mid-papillary and apex, as well as the 2D or B mode of the left ventricle and apical 4-chamber, 2-chamber, 3-chamber, and the RV focused view and apical view. So these clips, ideally, we like to have an Acquire 2 instead of Acquire 1 so that we can run it as a speckle tracking. This is pretty much how the machine works. When you're done, you can do end exam. If you forgot to do some images and you want to go back, you can go and review, select the patient, append, and do add.
You open the same.
It will open.
Action.
Exactly. So you restart 2D, your images will appear.
The protocol is a long protocol? Or is it
It's a standard. I'll send it to you.
That's fine.
We'll go over the images. I just want to show you that at the beginning, the first image, we like to have the number of the study ID.
Sorry.
No worries. We like to have the number of the study ID, the blood pressure of the patient, the weight, and the length. So the way we do that is that we use the label option. And then on label, we put the information here on the keyboard. So I don't know if it's study from Sarabi or another study. Let's say it's...
Can I see that
yeah.
the VPN?
Yeah. So you can use... So I just want to show you, use pointer. Once you have your pointer, you can go, and then you can go select your image. Oops. And then you have the image. So then the study number, the blood pressure, the weight, and the length, so that we can do the calculation later. And then, so let's say I would do it now. You have to go in label. You put your info. So Sarah B number XXX. Then you put the BP, the weight, the length, and then you freeze, and then you acquire. So we acquire the image. When you go back to 2D, don't forget to erase so that your entire study doesn't contain this information. So that's for in general. There's other options to adjust your gray map or the X-res, which is the filtering artifact of Philips. So there's different. Typically we keep it in the middle, and it's been the most appreciated filtering artifact. TDIs I mentioned are here. The protocol is pretty standard. I'll be going through in the video that I will create like the whole sequence of images, and I'll send you also on paper format. What we do is we start with parasternal. Well, you can start whichever view you prefer. You know, what we try is not the imperfection, it's just to get the information. We do a parasternal long axis view. In this parasternal long axis view, we start with regular to see the LV, the mitral valve, the aorta. We then put color to see blood flow, to see if there's mitral insufficiency or aortic insufficiency. We then do an M mode at the tip of the mitral valve. I know it's not standard for ASC anymore, but we do it for the protocol. We do an M mode through the aortic LA junction. Then we take a zoom of the aortic valve for a few clips so that we can measure the valve. Then we put color through that zoom. We acquire it. Then in the 2D, we go anterior to the pulmonary RV outflow tract. We acquire this. We take a zoom of the pulmonary valve. We acquire this. We put color through the pulmonary valve. We acquire this. We do a PW at the RVOT, so at the level of the valve, so we can measure output later on. We do a CW to see if there's pulmonary insufficiency or not. Then we do posterior sweep. We go to the tricuspid area. We save. We put color on tricuspid valve. We then do a CW through tricuspid valve, PW at the entrance of the tricuspid valve, because sometimes in
short axis.
In long parasternal long. Posterior view. Yeah.
Oh, okay.
Because sometimes we found that in pregnant lady, it's very difficult to get views, and it's the only place where we get like EON A. Then we turn to parasternal short. We do aortic valve view. We go to the mitral area. We go mitral valve view. We do mid papillary. We do apex. We try to get at least 3 beats at each segment. Then we do color. We take pulmonary valve. We re-put the color on it. We try to take a PW at the pulmonary valve, CW at the pulmonary valve. We try to get TR if there's TR there too. Then we go in apical view. We do apical 4-chamber LV focused. We get TDI lateral wall, TDI septal wall, and then TDI RV lateral wall. We get PW of the LV inflow, RV inflow. We get CW to see if there's TR. Then we do a 2-chamber view in 2D. We do a 3-chamber view in 2D of the LV. We then put color at the LVOT. We capture, and then we try to get PW at the LVOT. We also try to get 1 pulmonary vein in the apical view, if able, like the right upper pulmonary vein for a PW Doppler. Then after that, we do the 3Ds of the RV, 3D of the LV. And then we try to do subcostal, but in pregnant lady it's very difficult. So I don't want you to like spend an hour, and I don't want us to press or anything. So if we're able to get with gentle, we do it. So mostly to see if there's an interarterial shunt, the IVC, and then if we can get the abdominal aorta for a PW. And then we finish with a suprasternal view just to see the arch, and we do with color, and then we do a PW ascending and then PW descending.
Ascending is
Yeah, to measure
Just
resistance.
PW.
Yeah, just PW for like the resistive index. And then we're done. So it's a pretty
you're gonna
standard
send that
protocol.
for sure, the video and
Yeah, yeah.
And for this, this is just for you, yeah, the video.
No,
Or you're gonna send
I'll
this
send it to
video?
all the
Yeah, because
technologists.
I
Yeah.
cannot, remember
Of course,
everything you
of course.
said today.
That's why we're doing the videos,
Just to
so
be
that
faster, yeah.
exactly. So you'll have all
That's
the information on the video, and then I'll go through also an image acquisition and
Yeah.
through the protocol, and you'll receive a paper of the protocol.
Soon we're gonna get these machines.
Oh, yeah?
They
I-
bought Philips, yeah.
Yeah, I think. Yeah, you're.
It's a good machine, huh?
Yeah, the machines is
Yeah, I
giving.
see.
I mean, it's not great because I'm standing, but
Yeah, no, that's a 3D probe, you said, which is
Yeah.
a small, it has a small tip,
small
which is very
footprint.
good.
Yeah. So you see, like I'm standing, and it's.
Oh,
I mean,
it's amazing, yeah.
the images.
The quality is good, very good.
And I'm not the most echogenic person, so I mean it's pretty nice, and there's a lot of algorithms to adjust, for your. So here I see all my walls, and I'm talking,
Yeah, I see some.
and it's very user friendly.
It
So
is, yeah.
so
We should get used to that.
Yeah.
Because our buttons are different, as you know. but
yeah,
some-
I know.
Some of them are combined.
So here you see, like if I want to increase my Nyquist, I could increase my Nyquist,
Mhm.
and then I could go and get my PW at my LVOT. And this is a 3D probe, so we'll have the 2D probe, which also hopefully soon is giving very good quality images. And so you don't have to use the 3D.
But the volume you said RVLV, it's part of the protocol. Yeah?
It's part of the
Part of the
protocol.
protocol.
Yeah.
So we have to use it.
Exactly. Well, you could use it just for the 3D if you're obtaining better images, because I found that, like for example, in our pediatric probe, the 2D gives exquisite quality. The 3D is good for 3D, but it's not as good for the 2D. The 2D is really like you just put the probe and you see everything.
Yeah.
Okay, that's it. Thank you very much.